Hi, my name is Clinical Gladys and you're watching the video Thyroid Eye Disease Clinical Characteristics. In this video, we'll be discussing what to expect of a patient who has been diagnosed with thyroid eye disease in terms of the signs and symptoms that they may have during both the wet phase and the dry phase of the condition. Let's commence with the wet phase. You'll recall from the previous video that this is the phase that's active and it's the inflammatory phase. So we have an increase in the orbital volume, we've got enlarged extraocular muscles and a swelling within the orbit. So with that will come a series of clinical signs and symptoms that we need to be aware of to diagnose the patient with thyroid eye disease. Some of these include upper eyelid retraction, lid lag, proptosis, as I just mentioned before, enlargement of the extraocular muscles and mechanical restriction of the extraocular muscles. And here I've included also the reasons for these sorts of symptoms. So with the lids, we have sympathetic overactivity of the Mueller's muscle, which causes upper lid retraction. And the reason we have proptosis is because of increased orbital volume. In terms of the extraocular muscles, we saw in the last video that we have an increase in muscle volume, and subsequent to this we also have mechanical restrictions. Let's go through each of these signs individual and have a look at some images of patients with thyroid eye disease. In relation to the lids, there's two signs we see: upper lid retraction and lid lag. Let's start off with the upper lid retraction. What's normal is that the upper lid should cover around 2 millimeters of the cornea, like we see here on the left eye. With upper lid retraction, the upper lid is retracted. We can see here that this is the case, and we can now see the upper component of the eye because it's retracted back. This actually gives the patient this look as though they're staring, and many patients will comment on the fact that they look different and their eyes look different, and that people think they're staring at them, and it's because of this lid retraction that's occurring, as well as later we'll see around the proptosis that makes things worse as well. In terms of lid lag, which is also known as the von Graeff sign, what we see now is that the upper lid lags behind as the patient looks down. So again, the same gentleman here, if we look at him looking down, we can see that this right eyelid is lagging behind the left eyelid. Now, with the increase in the orbital volume, what can happen is proptosis or exophthalmos. And this brings along with it, in addition to the lid changes that we just discussed, corneal exposure. We can see the patient below here has significant proptosis, has that upper lid retraction, and has that look of staring at you because of those two signs, the exophthalmos and that lid retraction. These patients, as I just said, they're at risk of corneal exposure, and we'll talk about managing this a little bit later. But their cornea can be compromised by thyroid eye disease. During the wet phase, we also see soft tissue involvement, and we can see here the patients have quite a bit of redness, and we've got lid edema here. So what we see is conjunctival chemosis, redness of conjunctiva and lid edema. These are classic signs of a patient who's in the wet phase and during the active phase of the disease. The patient above also, you can see on top of the soft tissue involvement or the chemosis in that particular instance, also has exophthalmos. I've mentioned several times that we will see enlargement of extraocular muscles in thyroid eye disease. And here on the scans to the right, we can clearly see that the medial rectus here is quite large. The lateral rectus here is much thinner. And again, the medial rectus here is quite large. So if you go back to what a normal orbit should look like, those muscles should be a lot thinner. And so they're expanding in size. And here is your optic nerve. And of course, we now are risking that optic nerve being compressed by that extraocular muscle. The enlargement of these extraocular muscles will result in, or can result in, mechanical restriction of eye movements, and often the patient will actually come and complain of diplopia as one of the first issues that they have. So the ocular motility issue could be unilateral or bilateral, and this mechanical restriction that we see can actually occur both in the wet and in the dry phases. Patients will also often complain of pain on movement when you're asking them to move, particularly away from the site of the restriction. The patient may complain of pain. The other thing that we'll see is an increase in IOP on eye movement. Again, that's one of those classic signs around mechanical restrictions, where we see IOP increases when we move in the opposite direction to the restriction. And you may also see globe retraction due to the mechanical restriction that's present. So due to the enlargement of the extraocular muscles and the increase in the orbital volume, then we can expect that some patients will be at risk of compressive optic neuropathy. It is actually fairly rare, but clearly it's sight-threatening and needs immediate action when this is occurring. So disc swelling will be seen, and colour vision changes will be seen. So obviously you'll be doing NSS and colour vision in these patients, and visual field changes will also occur in relation to this. From the patient's perspective, in terms of their complaints, they'll obviously complain about the signs, the exophthalmos, the staring, the redness. But in terms of symptoms, the things that they usually complain of is discomfort, which is coming from either pain on eye movements or that corneal exposure, which is creating dry eyes, and they'll have some photophobia and epiphora, etc. They may also complain of diplopia due to the extraocular muscles being involved and due to those mechanical restrictions. And if the optic nerve is being compressed, they may also complain of loss of vision or change in vision that's occurring due to compression of the optic nerve. Now, what's happening in the dry phase? In the dry phase, we've said that the inflammatory process is coming to an end and fibrosis is starting to settle in, and we're getting contraction of extraocular muscles, etc. During this process, there should be improvements in those soft tissue changes that we saw. Proptosis should reduce. There will be a decrease in the orbital volume, so the risk to the optic nerve reduces. So the disease is settling down, and one of the remaining issues that we have is eye movements. And so the patient may continue to complain of diplopia into the dry phase, or it may be reduced dependent on whether both eyes are affected, if there's symmetry, and so forth. One thing to note is that because this disease can last for some time, patients' fusion range can begin to extend in trying to accommodate for deviation. So it's not a surprise sometimes to find that these thyroid eye disease patients have extended fusion range, just like we talked about with long-standing neurogenic palsies. These patients, because their extraocular muscle issues can last for some time, some patients will obtain extended fusion ranges. So just focusing a little bit more on the extraocular muscles, the extraocular muscles actually have an order in which they're most frequently affected. The inferior rectus is the most commonly affected muscle in thyroid eye disease patients, followed by the medial rectus. Okay, these are actually the two most commonly affected muscles, the inferior rectus and the medial rectus. And then lastly, we have the superior rectus, and the lateral rectus is least affected. So the restrictions we see, or the mechanical restrictions of the eye movements we see, relate back to which muscle's been affected. So remember, with mechanical restrictions, usually the restriction is in the opposite direction of the action of that muscle. So with the inferior rectus, it's a depressor, and if that has become fibrotic, we're going to have issues going into upgaze. If we have the medial rectus affected, abduction will be affected. If the superior rectus is affected, down gaze will be problematic, and if we have the lateral rectus affected, adduction will be the issue. Now, it's noteworthy that a bit like myasthenia gravis, thyroid eye disease can be a great mimicker of various incompetence strabismus. So it is important that you take a careful history so that you can diagnose your patient appropriately. Let's have a look at a couple of Hess charts from patients with thyroid eye disease. In this particular example, we have a patient who has their left eye affected, and we can see that labial elevation, direct elevation, and dextral elevation is affected. So the entire elevation is affected. So this will look familiar to you. It looks like what we see in a blowout fracture of the floor, or it looks like a double elevator palsy. So a careful history is really required to ensure that your diagnosis is accurate. And like I've said many times, never diagnose a patient by only using one clinical measure or one clinical outcome. Okay, and lastly here we have a patient who has thyroid eye disease and has bilateral symmetrical limitation of abduction. So we can see here that abduction is affected quite significantly, and here again on the left side or on the left eye, abduction is affected significantly. So this does look somewhat like a bilateral sixth nerve palsy where we have the two lateral recti affected, and we seem to be seeing the sequelae or the related sequelae where we have the ipsilateral antagonist overacting. So again, careful history taking, ensuring that you do a thorough examination should get you to the right diagnosis. Okay, so far we've discussed what we expect in thyroid eye disease, or the types of signs and symptoms patients experience with this condition. Now, all patients will vary. Some patients will be more affected than others. And in the past, it's been difficult to actually determine the extent to which a patient is affected. Perhaps not determine how affected they are, but to have consistency between clinicians in terms of determining the level of activity or the level of severity. So the European group on Go has done quite a bit of work to create scales in order to be able to measure more accurately and more comparatively patients in terms of two things. One, around the activity of the condition, and I mean activity in relation to, are we in the wet phase, is it active or inactive? And then secondly, what is the severity of the condition, which will guide generally management. So starting off with signs of activity. Signs of activity you'll see I've listed there as eyelid redness, conjunctival injection, etc. So there's lots of those soft tissue issues relate back to signs of activity. And here to the right we have the CAS scoring system, which is a clinical activity score, and numerical values are appointed to each sign or symptom. Generally speaking, a score less than 3 indicates that the patient is in an inactive phase, and a score greater than 4 indicates that they are in the active phase. Now, classification and scoring or grading system has also been developed to determine severity. You don't need to know this in depth, but you need to be aware that a classification system does exist. It's called the NO-SPECS classification, and each letter has a meaning. So N means no sign or symptom, O only signs of upper lid, S soft tissue involvement, P proptosis, E extraocular muscle involvement, C corneal involvement, and S sight loss. So that makes the word NO-SPECS, and as we go from N to S, we're progressing further and further in terms of severity. And here to the right we have from Ansons and Davis the classification or NO-SPECS classification and the grading system that guides clinicians who work with patients with thyroid eye disease. So upon completion of grading and classifying the patient's thyroid eye disease, patients are classified as either being sight-threatening, in which case immediate action is required, and then there's moderate to severe, in which case treatment can be considered, immunosuppressants generally if you're in the active phase, the patient's in the active phase, or surgery if the patient's in an inactive phase. What's taken into consideration is also the patient and their function. So this treatment would be prescribed if the patient is impacted on in terms of lifestyle and function. And then finally, you have your mild patients whose function isn't impaired and their signs and symptoms are very mild as well, in which case these patients generally are monitored and don't need any immediate treatment of any sort. Now, before concluding, I just wanted to talk to you about the clinical investigation of a patient with thyroid eye disease. Because of the additional issues that thyroid eye disease brings with it, there's going to be a more ophthalmic component to the investigation of a patient with thyroid eye disease. Firstly, the things that you should be doing in a patient with thyroid eye disease is looking for any signs of optic nerve compression. So that means always measuring VA, which you always will do, but contrast, colour vision and visual fields are also required. And these are things we don't necessarily or routinely do in strabismus patients, but in this cohort of patients who are presenting perhaps with diplopia, they also need these further investigations to ensure that the optic nerve has not been compressed. In terms of the orthoptic examination, not much has changed there. All of that is fairly standard. And because you have a mechanical restriction, you can expect that FGTs can be positive in these patients. Just going back now to some more ophthalmic investigations, because of the proptosis and the corneal exposure, then we do have, or the patient is at risk of having damage to their cornea and keratitis. So a corneal examination should be performed on all these patients on a routine basis. And the fundus examination, obviously you want to have a good look at that optic nerve each time you see the patient. And finally, because the lids are involved and we have proptosis in these patients, assess the lids, measure the exophthalmos in these patients as well. Okay, so in summary here I've provided you with a list of the signs that we may see in a patient with thyroid eye disease, and then we have the symptoms, so what symptoms the patients tend to complain of. Here to the right from Ansons and Davis, there is also the mechanism by which these signs and symptoms occur. So as an example, again with the upper lid retraction, it is Muller's muscle hyperactivity that leads to that particular issue. Okay, that brings me to the conclusion of this video. Thank you for watching.